want to exploit the force and the work of the patient to ventilate for himself a variable proportion of what we want as total ventilation. The patient does have to work, but we have to know how much we want him to work and how much he is working. It's like training an athlete. So how to assess patient's effort is basically how to assess the proportion of work the patient is doing. And why do we want to measure that? Well, the first reason is the basic one, because we want to titrate how much the patient is working. We do not want to kill him by fatigue. And that helps understanding weaning failure. Some patients will not be able to stand the amount of work we are asking them to do. Then we are taking care of the patient too, but we have to take care of his lungs too. And these lungs, we know, are damaged by pressure. So monitoring the patient's effort, you will see, is a way to monitor the total pressure applied to the lung of the patient. In controlled mechanical ventilation, the bad guy is the ventilator. Here, we have two bad guys because we have two forces acting on the lung, the ventilator and the patient himself. Not because the patient is stupid. The patient usually is very wise, but sometimes he does not know how to handle his problems. And that is why we are there, to titrate how much effort he has to put in his lungs to move them. And that is minimizing the work of ventilator-induced lung injury, this magic word for lung damage, ventilator-induced lung injury. This is, I think, one of the first published evidence that the patient effort might damage the patient. The mechanism here is quite complex, but basically, I'd like you to follow the esophageal pressure, baseline, controlled mechanical ventilation. As you see, the changes in esophageal pressure are very small. 5 minutes of spontaneous breathing. Look at the changes in esophageal pressure. What does it mean when esophageal pressure is minus 20? It means that transpulmonary pressure, if the airway pressure is 0, it means that at end inspiration, transpulmonary pressure is 20, even if the airway pressure is 0, because the patient is applying a negative pressure around the lung, and the lung inflates. And the force that is inflating the lung is 20 centimeters of water. In the late 90s, late 90s, the US were trying to assess the beneficial effect of low tidal volume against high tidal volume. The study kept assist control ventilation on patients. And patients switched from 12 to 6 milliliters per kilo, sometimes at a high inspiratory drive, because they felt 6 milliliters per kilo was too small a tidal volume. Some of those patients actually went into pulmonary edema because patients were trying to inspire at higher flow than the one provided by the ventilator. And their intrathoracic, that is esophageal pressure, became very negative. So the transpulmonary pressure was high in spite of the ventilator being set on a small tidal volume. So, and as a matter of fact, we know that if we increase airway resistance very much, sometimes this causes pulmonary edema because of the conflict between high resistance and high applied pressure across the lung. And that might be one of the reasons that led to the advantage in survival when controlled mechanical ventilation and neuromuscular blocking agents is applied early in severe ARDS. Because sometimes spontaneous activity might be damaging, and we have to know what we are doing. So, and this is in severe ARDS as an example, particularly in the early phases of severe ARDS, this might be a real problem. It's the main reason why assisted breathing is sometimes not applicable in severe ARDS patients. And as an example, sometimes it is possible if you apply extreme technology. As an example, this is a patient with severe ARDS breathing spontaneously, but is breathing spontaneously in spite of his very high respiratory drive because there is a trick. And the trick is that his gas exchange is provided by an artificial lung. Otherwise, that would not have been possible. This is another case. Patient day 0 on controlled positive pressure ventilation with neuromuscular blocking agents. Then I came and I said, well, this patient is doing well. Why not to try spontaneous breathing? After 3 days, spontaneous breathing, obviously I was right, but somebody did not apply spontaneous breathing in the right way. No, actually, that was a mistake. This is a patient that should not have gone to assisted breathing because, as a matter of fact, his drive was so high that he got into hemorrhagic pulmonary edema, as the ones I show you in the first slides. Had we been measuring accurately what the patient was doing, we would have known that it was not the right time to put the patient into assisted breathing instead of controlled. So the problem here is how to couple the advantage of assisted breathing with our need to avoid damage to the lung. Because we know that if we prevent damage, it's much better than curing the damage. So the possible approaches are quite a few. The gold standard, what gives you the real measurement, the hard stuff, is esophageal pressure monitoring. This is pressure support as an example. You see the airway is raised during inspiration, the flow goes up and then goes down, and then the patient expires, and here is the esophageal pressure. If ventilation were to be controlled, the esophageal pressure will go up during inspiration because of the passive motion of the chest wall. When the chest wall is passive, then we have to apply a positive pressure to make it move. But if the chest wall moves because of his own muscles, then the chest wall sucks the lungs up, making a negative pressure around the lung. And you see here that in assisted ventilation, as opposed to control, in assisted ventilation, the esophageal pressure goes down. It becomes negative. The patient, as a matter of fact, is sucking air in. The difference between the curve during passive inspiration and the curve during active inspiration is indeed the amount of pressure generated by the patient muscles. If I want to know how much the patient is working, the best, the scientific, the gold standard is indeed the esophageal pressure. Because the difference between passive motion pressure and active inspiration is built by what? By the inspiratory muscles. So I measure directly what the inspiratory muscles are doing. And here you see that by monitoring esophageal pressure, you can follow a weaning trial. This is a success weaning trial. Esophageal pressure in changes are rather small, and they are constant. This is a patient that starts at -10 and ends the trial at -15. He will get fatigued because his work is increasing, and unless you put him back to the ventilator, he will die of his respiratory work. So this is a weaning failure. Why? Because the work we ask to the muscles is too high. It's like walking. It's too fragile to work. It's too fragile to breathe. The work we are asking him is much more than the work he can do. Again, if we monitor esophageal pressure, we can see that when the weaning is successful, the esophageal pressure swings, that is, the pressure generated by the muscles, is constant during time, while in failures, the pressure generated by the muscles increases with time. We better stop the test before severe dyspnea. Well, I know it's not exactly a straight line, but it goes up. And you could ask yourself why it goes up. Because if I give you a work to do, lift this table, the force I use does not increase with time. It's my force that goes down. Here, obviously, the work required increases, either because the patients become tachypnoic, but it's not so, or because the mechanical properties of the lung do change. Compliance decreases because of what? Interstitial lung edema, increased resistances, increased airflow. You know that in the lung, airway resistance changes with flow. The higher the flow, the higher the resistance, because of turbulences, Reynolds numbers, stupid mechanics. But the the harder you breathe, the higher the resistance. This is a patient breathing in CPAP. He does 100% of the work. Almost. This is a CPAP done by a ventilator, so as any machine is not perfect, but pressure is almost constant, plus minus 2 centimeters of water. And this is esophageal pressure. You see these swings in esophageal pressure? When we use pressure support, we provide an inspiratory assist. The ventilator does a proportion of the work. Can you guess how much work is doing the ventilator now compared to what it was doing before? Well, I have a rough guess, very rough, but at least we have a decrease of 50% because the inspiratory drop of the esophageal pressure is at least 1/2. You see that the inspiratory drop of esophageal pressure now is much smaller than before? If the drop is smaller, it means the respiratory muscles is lifting a table that weighs 1/2 because somebody else is pushing the table up. Obviously, the esophageal limitation is a gold standard, but it has sometimes some technical difficulties. It's difficult to keep it working for days. It's not something you can really rely on for weeks. You get there, you push the button, you get a good number. You always have to work a little bit on it. It's possible, it can be done. In the proper trained hands, it works perfectly. But it has some problems. We can guess, as an example, from airway pressure. Dr. Maggiore just told you how to guess the inspiratory effort of a patient under volume-assisted ventilation. But volume-assisted ventilation is very rare. Usually, we use pressure-assisted ventilation mode. And I believe that measuring PO1 is a very efficient way of predicting the effort. Or as I said, actually it's not myself, as somebody told me, PO1 is a way to measure how happy is the patient. A patient with a low PO1 either is drugged, very sedated, is happy anyway, or is very comfortable breathing. PO1 is a measure of how quickly the patient is trying to inspire. By interrupting the inspiratory effort, the patient will keep trying to inspire. The drop in pressure against an occluded airway is called PO1, the drop in pressure during the first 100 milliseconds. And it has been shown that there is a good relationship between work of breathing and PO1. It has been shown that PO1 predicts weaning success. And the good part of PO1 is that if you push a button on the ventilator will provide you a number. If you do it quite a few times, you get an average that tells you how much the patient is trying to breathe in. A normal PO1 is -2, 0 is not good. Between 1 and -2, -2.5. And after running 200 meters, PO1 in a normal subject is something like -8, -7. This is the PO1 of a respiratory distress patient. Sometimes we see even -10. If under pressure support PO1 is -5, the patient is not happy and he will soon fail. As here, see here, this is a paper published by Bellani in our group, and Weaning successes had a very constant PO1 in spite of changing the level of pressure support, while patients failing the Weaning test very quickly increased PO1 up to -6, -7. This is another way of measuring patients' effort, is what we have called muscle pressure index. During controlled mechanical ventilation, the one that works is just the ventilator, with this square box here. In assisted ventilation, the patient applies this negative pressure, that is the negative pressure he makes in the esophagus by his muscles. So the total applied pressure is this one. Now, if we occlude the airways at end inspiration, sooner or later the patient will relax his muscles. And now we can measure the total pressure applied to the respiratory system, because the esophageal pressure has gone back to 0. And this difference between end inspiratory pressure and the relaxed pressure is a measure of how much the patient was trying to inspire approaching end inspiration. Is a measure of the pressure is an estimate of the negative pressure developed by the patient towards the end of inspiration. And this is an example of how PMI is very small when the support is very high and becomes 3 or 4 times higher when the support is small. This is pressure support of 30 centimeters of water. This is pressure support of 10 centimeters of water. The last thing I want to tell you is about the electromyography of the diaphragm. I skip the monitoring of the oxygen consumption because it's complex and is vastly experimental. It's very promising, but measuring oxygen consumption sometimes is tricky. The measure of the electrical activity of the diaphragm is the electromyography of the diaphragm. And there are means, luckily enough these days, to perform an electromyography of the diaphragm using a specific catheter that is normally it is used to perform neurally assisted neurally adjusted ventilatory assist. I never learned that. Normally called NAVA. But you can use the electromyography to understand, not to dry the ventilator, but to understand what the diaphragm is doing, exploiting the fact that you have indeed a working electromyographic signal of the diaphragm itself. You see here a patient undergoing CPAP, once again. Now we have the esophageal pressure and the electromyographic signal. You see that the electromyographic signal, in a way, mirrors the esophageal pressure. And if we use pressure support instead of CPAP, the electromyographic signal decreases, paralleling, mirroring the decrease on the effort we measure with the esophagus. I've put here the electromyography of the intercostal muscles, because you can use, I mean, it's not a golden rule that you have to use just the diaphragm. You can also have an electromyographic signal from the intercostal muscles. It's a less developed technique, but in principle you can. And this is a particularly lucky case in which the costal margin electromyography is very similar to electromyography of the diaphragm. Now, obviously, it's possible to demonstrate that the electromyographic signal of the diaphragm parallels the force developed by the diaphragm. And we are lucky enough to be able to convert the electrical signal into centimeters of water. How can we do that? How can we convert microvolts into centimeters of water? Now that we know it, it's very easy. If we occlude the airways and the patient makes an inspiration, the change in esophageal pressure equals the change in airway pressure, because there is no change in volume. So all the system is static. The only thing that happens is that the inspiratory muscles are pulling out and the system gets decompressed without changing volume. The change in airway pressure equals the change around the lung. No change in volume, no transpulmonary pressure. If I have -5 in the airways, if the difference between inside the airways and outside the lung has to be 0, if inside is -5, how much will it be outside the lung? -5. No change in volume, the transpulmonary pressure has to be 0. Now, if I perform the electromyography of the diaphragm during an occluded inspiration, zero change in volume, then the change in microvolt will tell me how many centimeters of water have been developed. Where do I measure the centimeters of water? In the airways. Now I know that, as an example, 5 microvolts will generate -10 centimeters of water in these patients today. Tomorrow, it might be that 5 microvolts will be -5 centimeters of water, or -20, because it changes from patient to patient and from day to day. But you can calibrate it with an inspiratory occlusion as many times as you want, as long as the electromyography works. And as a matter of fact, we have been able to show that using the electromyographic signal calibrated in such a way, we can actually estimate quite accurately both Pmusc, that is the pressure developed by the muscles, and the respiratory work. And to end my talk, this is a monitoring of the electromyographic signal during pressure support, small signal. During CPAP, the signal increases. During T-tube, it goes up, 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 up during the trial. Then it's better we go back to CPAP. So what are the... my time is up, Mr. Chairman. So we have esophageal pressure is the gold standard. We have airway pressure-based methods, PO1, PMI. Oxygen consumption, we did not talk about that, and we do not want to talk. And then the diaphragmatic electrical activity. In the near future, I hope we can have surface electromyography of the respiratory muscles, if it works. If it does not work, we'll publish them anyway somehow. Conclusions. Monitoring of inspiratory effort is essential in many cases because it might be very damaging. Esophageal pressure monitoring is the gold standard. PO1 is very easy. PMI works best in pressure support, and electromyography is promising. Please always consider that assisted ventilation might be as damaging and sometimes more damaging than controlled mechanical ventilation. Thank you very much.